So good afternoon to all. I'm really glad to have you all here. So welcome to our inaugural Global Health Hybrid event. So we have audience in the auditorium as well as virtually. So what will be happening is that we will have a live Q&A session after the 4 talks. But if you have any questions in between, those in the virtual world can actually type in the Q&A box and we'll be answering them along the way. So to start off our event, we'll have our opening speeches by Prof. Tan and Prof. Goh. Prof. Tan, please.
I'll take off my mask and I seek your forgiveness. A very good afternoon to all of you, and Prof. Goh Xiang-hyung, the chair of emergency ACP, Prof. Marcus Ong, director for the Prehospital Emergency Research Center, Prof. Jan Wnent from Germany, and I believe we have also Dr. Ashini from Duke. So I thought I want to really applaud the organizer for this very laudable goal of emergency medicine for all, capacity building across the border. I think it is fair to say that emergency medicine exists in almost all the countries around our part of the world, but the emergency medicine exists in very different form in Singapore versus in Germany versus in Thailand versus in Laos. In fact, in my recent trip in Cambodia, when speaking to Ministry of Health officials, politicians, policymakers, hospital leadership, department leadership, it came loud and clear that capacity building for emergency medicine is something that is much needed, and it is a universal request from our partners in the region, and not just in Cambodia, because we have similar requests from other countries in Southeast Asia and South Asia. And I think I do want to applaud Emergency ACP for taking the bold step to launch this global health webinar, but also to take this opportunity to launch Emergency ACP Global Health Program. Clearly, addressing this requires a transsectoral approach. It is not just about capacity building within the emergency department. It is about understanding what brought people in the first place to the emergency department, how those can be prevented, and downstream, beyond the emergency department, what are the capacity that is available that we can help build so that patients are looked after even as they exit after emergency department. So I thought I would just take this opportunity to thank all of you and appreciate the time and effort in organizing this. And I would maybe hand this over to Xiang-hyung. I'm sure you enjoy the talk this afternoon by our various speakers. Xiang-hyung, thanks.
Thanks, Jan. Hi, good afternoon and warm welcome to everyone. Warm welcome to everyone, both online as well here in the auditorium. It's very nice to be able to see people face to face after 2 years. And also to have overseas visitors, which we haven't had for the longest time. I echo Jan Kun's thanks to Marcus, Director of the Duke PERC, Prehospital Emergency and Research Center, and also to SDGHI, the SingHealth Duke Global Health Institute, for helping us and supporting us in this afternoon's activities. So for emergency medicine, for close to 20 years already, our emergency physicians have been going around the region, helping train paramedics, emergency physicians and nurses. Both our adult and pediatric emergency departments have gone on such missions to places as diverse as Malang, Indonesia, Sri Lanka, Nepal, China, and many others around our region. And we've been building capacity, like I mentioned before. But I think that is important and timely to look at a new phase. And we should be trying to go into research to assess the outcomes of our efforts. Until now, we've seen systems built, but we haven't been able to quantify and measure the outcomes, the effectiveness of that. And I was mentioning and discussing with our visitors just now, perhaps it's time that we go into such research, right? We know that Marcus and some other Asian partners have already gone into PAROS, the Pan-Asian Resource Outcome Study, and PATOS, the Pan-Asian Trauma Outcome Study, which I think is a grand initiative, and we should continue to build on such research in order to measure our outcomes. Once again, I hope that all of you have an enjoyable afternoon listening to our esteemed speakers from Germany as well as Duke-NUS. And I'll just hand the mic back to Gaia. Thank you.
Thank you, Prof. Goh. Okay, thank you very much. So before we start off with our talks, it takes me great pleasure to actually launch our EME-ACP Global Health Group. So I'd just like to take a few minutes to just introduce our team members of this global health team, which would come under the EME-ACP clinical services. So next slide, please. Yeah. So we have our team members. So first, there's me, Gayatri from Emergency Department. We have Dr. Arif from KK Children's Emergency. We have Dr. Chong Shuling from KK Children's Emergency. And we have Suraida from Sengkang, and Charlene from Sengkang also, and Dr. Shun from Sengkang. Right. So next slide. Right. So okay, there's nothing on our plate at the moment. So we would welcome any feedback from you guys to on how we actually can help develop this arm, help to develop your global health interests. So do scan this QR code. It's really quick, 2 questions on how we can play a part in your development. Thank you very much. Okay. We'll type the link in the chat also. Yeah. Okay, right. So we're moving on to our first speaker, all the way from Germany, amidst the tornado. Okay. Right. So we have Dr. Jan, who's going to be talking about how the simplest intervention can make the biggest difference. Dr. Jan, please.
Yeah, thank you very much. Dear professors, dear colleagues, thank you very much for inviting me to give this talk about my experience in Windhoek, Namibia, where I've served as an head of department for the so-called acute care unit for at least 2 years. It is something between an ICU and emergency department. And I wanted to warn you that I will not give you a scientific talk. It's more an experience-based report, what we have done the 2 years and what I have found on the ground when I started there end of 2018, and what we have done on very simple interventions to reduce mortality and to improve patients' care. Oh, are the slides moving? Maybe not. Okay, next slide, please. Just to give you an impression how big Namibia is and how sparsely populated it is. So I've put it Namibia versus Singapore. So Namibia has a size of 825,000 square kilometers compared to Singapore, as you know, roughly 730 square kilometers, with a population of 2.5 million that ends up of a population density of 2.82 per square kilometer compared to your country, what is roughly 7,900. So I think in one block in Singapore are living more people than in the whole capital of Namibia, what is Windhoek. What has officially, let's say, 400,000 inhabitants, but nobody knows how many because there's no formal census and there's no formal system in place that you have to register. There is a birth registry in place since a couple of years, but nobody knows how many people are living in the country. So the Secret Service and the United Nations are estimating it 2.5 to 3 million. So very sparsely populated, with Windhoek as the capital in the middle. And then the majority of the people are living here in the north, in the Ovambo area. That is, compared to the rest of Namibia, what is farmland and what is desert here in the south, in the Karas region. It's more rural Africa, where you have really small villages next to the streets. The rest here is farm area, where you have huge farms, several thousand square meters big. So there's the population density even lower than the 2.8. Next slide, please. And of course, we have some very common inhabitants of Namibia. We have the wildlife, we have the lions, we have the elephants there. Next slide, please. And of course, I wanted to show you a little bit of the landscape, and that is the other part of the work when you are working abroad, and when you are working, especially from my perspective, in the African continent. Of course, you have your work, what is mostly very challenging, because you are facing problems, especially in emergency medicine and in intensive care medicine, what you are not used to from your training when you've been trained in a fully developed healthcare system. So I've never thought, when I served as a resident and as a consultant on ICU at university in Kiel and in Lübeck, that I have to make decisions of triage, for example. We had 8 beds on our ICU. So every day, it was a decision to triage patients, to say, okay, this 90% of patients I will not take on ICU because there's no chance for survival, and I only will take this 10%. So you need to get a little bit of recreation, therefore you need to discover the landscape. And just to give you a little bit of impression what we have done outside the hospital, traveling to farms, enjoying the sunset, for example, having a nice sundowner gin and tonic to prevent malaria. Even though Namibia is not a malaria area, it's only the northern part of Namibia what brings us the problems with malaria, usually. Next slide, please. And there we come to malaria, the most dangerous animals. I think by far the most dangerous is this one, the mosquitoes. Even though the major area of malaria endemic is the northern part, and especially in the rainy season, we have seen quite some nasty malaria patients on the ICU, because we were one of the 2 big referral hospitals in the country. And when the smaller district hospital medical officers or regional hospital medical officers didn't know what to do, they basically put the patient in the ambulance and sent it to Windhoek. And then we have 2 hospitals, or we have 2 hospitals in Windhoek. That is Katutura State Hospital, or Katutura Intermediate Hospital, where I've worked in, and we have Windhoek Central Hospital. I will come to it a little bit later. And we have the other one, the hippos. They are more dangerous than the big cats, the leopards, the cheetahs, the lions, because they are just squeezing their victims to death. Fortunately, we haven't seen much injuries related to hippo attack. What we have seen is 2 injured patients secondary to an elephant attack, where they have just sticked the tusks through the chest. The one was 85 years old. He has survived, fortunately. The other one has died. Okay, next slide, please. How is the healthcare system organized and financed, just in brief, in Namibia? It's a tax finance system, and it's organized by the Ministry of Health and Social Services. So there's no health insurance. Everything is tax paid. Only that when you're going to the hospital, you have to pay a small entrance fee. Like I think it's comparable low. It's around 10 Namibian dollars. It's a few euro cents you have to pay, and then you're getting in the healthcare system, in the state-driven healthcare system. There are smaller hospitals for primary care and smaller outpatient clinics in every district, and we have an hierarchical structure according to the regions. So we have 14 regions in Namibia with regional hospitals, and some more districts within the regions having small district hospitals or health posts or so. usually those hospitals, especially the regional hospitals, are capable to deliver basic internal medicine treatment, surgical treatment, and obs and gynae, what plays obviously a big role in a population that is relatively young compared to the European or to Singaporean population, for example. Mostly driven, the hospitals, by medical officers. That time when I started in Namibia, we had in the whole medical community, I think it was 58 specialists over all disciplines. And 80% of the specialists were located in Windhoek, because when they are not expats, they are driving their private practice there in Windhoek, and that is the place where you can earn most of the money out of your work. And some have worked in the northern part around Oshakati, where a majority of the people live. But of course, there are not that many people that can afford private healthcare. There are 4 referral hospitals. That is Windhoek Central Hospital. That is Katutura Intermediate Hospital, also in Windhoek. It's due to historical reasons of apartheid that there are 2 big hospitals in Windhoek. The Windhoek Central Hospital was during till 1990 the hospital for the whites, with the highest standard of care. The Katutura Hospital was the hospital for the black people. And Katutura is also one of the parts of Windhoek city. It's, when you translate it from Oshibambu, what is the language mostly spoken in Namibia, it translates in the place not to be. And people are usually scared to go to Katutura Hospital. It has improved over the last 5 years, but especially the elderly people, they really don't want to go to Katutura Hospital because they know from the ancestors that people will die there and that the treatment will be not to say bad, but not optimal. And that is something we had to deal with during my time there. And then there's Oshakati Intermediate Hospital in the north and Rundu Intermediate Hospital in the Caprivi area. That is this small stretch of Namibia between Zambia, Zimbabwe, and Botswana. Rundu, it's from Windhoek, it's 1,200 kilometers. And you can imagine when we are getting, or when we got a patient with an intracerebral bleed, for example, referred from Rundu Hospital with a ground ambulance, 1,200 kilometers. In the 2 years, I have seen, I think, 1 or 2 patients who have survived arrival in Katutura Hospital. The rest died basically during transport. Ambulances are run by the Ministry of Health, but usually are meant for inter-hospital transfer and not for primary admissions. And they are staffed with a driver and with a nurse, not specially trained in emergency medicine, but a nurse, a registered nurse from the hospital. And they are usually not equipped with ventilators. There were ventilators on the ambulances, but the administrators have removed them because they thought they will be stolen. So there is simply an ambu bag, an oxygen cylinder, and someone who is bagging the patient over 1,200 kilometers with a simple SATS clip on the finger, what they mostly purchase privately, the nurses and the doctors, through Amazon. And that is the monitoring. So it's a little bit challenging. And there's the private healthcare sector. You know, it's like the private healthcare sector everywhere. It's up to US or EU best standard. As long as you can pay cash out of your pocket or you have a private health insurance, you can go there. And there you can get everything from your cabbage to your aortic valve replacement up to Botox, whatever you want to. And most of the consultants are working in private as well as in state. So they are internal medicine consultants. I was related to internal medicine. They did their wartrons in the morning in state, if they did, and then they went to their private rooms. In terms of infrastructure, we did a bed count at the beginning of the COVID crisis. And in the whole country, in private and state, we counted in total 120 ICU beds. How many ICU beds you have here in Singapore in General Hospital? I think the same number or even more. In Kiel, at our campus in Kiel, we have 112 for a population of 300,000. So it's quite low. So you have to have a hard triage there. Next slide, please. This Katutura Hospital, as I said, is the biggest hospital in the country. It has approximately 850 beds. Nobody knows exactly There was a report done by a consultancy firm a couple of years ago saying that this hospital needs to be renovated, refurbished, better to be demolished and built new. And nobody knows how many beds are really can really be run. We have covered internal medicine, general surgery, traumatology, and orthopedics. What is one? Obs and gynae and pediatrics, as well as the emergency department, what was responsible for, or what is responsible for every patient, as well as my acute care unit, where we have served for every patient, regardless of the age group. So we started with the youngest one was around a month, and the oldest one above 90. I will show you in the next slide, please. Yeah, this is basically the casualty department, the emergency department. That is our resus room with basic equipment, and the internal medicine room, let's say, it's called big room, where you have 4 beds at each side, and usually it is as crowded as you know from your emergency department that you put stretchers or mattresses somewhere, especially on referral days. That's interesting though, the different regions have specific referral days. Let's say from the northern regions on Mondays, on Wednesdays, there are big buses coming, bringing patients from the regions referred to Windhoek, let it be for CT test or for complex intervention of whatever condition. So then the patients are really piling up, and you have to triage first in the emergency department, and then, of course, the patients that might be critical, you have to triage again for entrance on ICU or not. Next slide, please. This is to give you an impression of the, okay, thank you, of the acute care unit. As I said, it's an 8-bed unit. It's quite old. The Katatura Hospital was built in the late 1970s, and it was never really maintained. That was a little bit the challenge. We were able to run 8 beds from the space. We have this open space here with 6 beds, and we have 2 cubicles where we can more or less isolate patients. Usually we have used the cubicles for burn patients, for example, just to separate them a little bit from the rest of the patients. It's not eligible for patients with highly contagious infectious diseases, for example. We have used it for COVID, but during COVID pandemic, or the first waves of COVID pandemic, we have set up a special ICU kind of high care unit for the COVID-related patients, for the suspected cases and for the confirmed cases. Next slide, please. It's not working. Ah, no, it's working. It's going the wrong way. Ah, okay. 8 beds capacity, as I said, a little bit of statistics. Our mean age of patients was 35 years. In Germany, the mean age of patients admitted to an ICU is above 65, 68. Oh, I have to hurry up a bit. 45% female. The average length of stay was 4.3 days with the maximum of 71 days. It was a 7-year-old female with multiple brain abscesses. She has survived the whole thing. Duration on the ventilator was that time 2.4 days in average with a maximum of 64 days. That was this patient. And 2/3 of our patients came from internal medicine, the rest surgery and ENT, obs and gynae, whatever you wanted to have. And the oldest one was 96 years old, what was really quite old, and where I had a lot of discussions why I have admitted a 96-year-old patient to this ward, because this lady was completely well before, and then she had whatever, I think it was heart failure or something, and she survived quite well and went out and went home. What have we done as first interventions? When I started there was no labeling of syringes and infusions, for example. There were syringe drivers running without labeling what is running there. So simple things, and that has driven mortality, for example, because the nurses and the doctors have mixed the medication and had caught theirs because someone got sedation who was not intubated and those things. That was the first intervention I've done. We have then, at the same time when I started there, started structured ward round schemes. we have included the nurses to the ward rounds. They were really reluctant. It was not usual for them to join the consultant ward round. After 10 days, 20 days, it was completely usual, and they asked for, doctor, when you wanted to start the round, we wanted to join, and then they took more responsibility for their assigned patients. We took the responsibility from the discipline of origin, from the internal medicine, from the surgeons to the ICU team and to the acute care team, and only consulted the discipline of origin for specific questions, like the surgeons, for example. We attended, or myself attended the morning meetings for the big departments, just to show up there, to show the face and to give a little bit of feedback, especially on the performance of the medical officers during the night. Training, the simplest one, how to secure a tube, to implement a standard, just basic standard. How to prepare intubation, for example, that you have it every time the same thing on your trolley. That was not implemented yet. We implemented teaching ward rounds. We implemented things like closed loop communication and something like team check. It's the 10 for 10 principle, a little bit adapted. In critical situations, they were not really aware. The doctors were, especially the foreign trained doctors that came from South Africa. But for the nurses, it was quite new. It was not on their scope. After a little bit of discussion, it worked really well, especially with the younger, motivated nurses. The SOPs, I will show you some, and we started a coverage of 24/7 coverage first with medical interns. There was no doctor responsible for the unit when I started there, so we started with medical interns, and the friend of mine, Dr. Sekubi, who took over now the leadership there, has managed to have a 24/7 coverage with medical officers as well. So we have interns and medical officers currently. That has reduced mortality as well. And we started a 24/7 consultant call. That was, in the beginning, was me, 20 days a month. And then we arranged a bigger group of surgery consultants, traumatologists, and internal medicine, just to spread it a little bit up. That has reduced our mortality as well. It has also, of course, regulated a bit, or has triaged the patients a little bit more. Some simple SOPs we have set up. This had made a big difference. The ward round scheme, for example, with this fast hack BID, what we have implemented, that is nothing really, it's not rocket science. It's just to have a standard for everyone, regardless who is doing the ward round, had to rely on the same standard. Basic ventilation things, huh? Yeah, it's outdated. It's 6. I still have written there 2019, 6 to 8 mils per kg. The new science, you know, it's more 4 to 6. But it's from 2019. And we have seen a lot of hyperventilated patients there. Or admission criteria. There were no admission criteria, not in writing. So we sat down with the internal medicine, with general surgery, to discuss admission criteria, who everyone could agree on, so that we have a baseline. And what we also have implemented was teaching ward rounds with guests from foreign countries. That was at the first University of Lübeck, then the Georgetown University colleagues and the colleagues from McMaster in Hamilton, Canada, who regularly sent residents to help us teaching, and they were really useful to teach our interns and our medical officers in certain topics. So really, really useful. And also here, discussions with the hematologists from Georgetown, for example, in special patients. What were the challenges? Out of stock issues. We dealt with a 6-month out of stock of midazolam. It's a little bit a challenge, let's say, for ICU to sedate patients. I really got to like ketofol, the mixture of propofol and ketamine, what is completely unusual in Germany. And I think you know it better, or the colleagues from US or in South Africa. For us, it's completely unusual. We had old equipment that were the ventilators we had. They were already outdated 2018 for 10 years. Our medical engineering guys did a great job to keep these machines running, even though like the old Philips monitors we had. There was no ABG, there was no 24/7 lab in-house, so we had to send ABGs to the lab the next hospital with a driver. Can't rely on this result. and some other equipment issues. No feeding pumps, for example, no continuous dialysis. And some curiosity, what I haven't expected before I went to Namibia, and I even though knew the Namibian healthcare system quite a bit before I went there, blocked tubes, for example, the humidity in Namibia in Windhoek is around 20%. And when you don't have a humidification of your ventilator circuits, your tubes get easily blocked. And this is an adult tube, a 7.0, but we have seen it frequently with the children, for example. So that was a really big issue, and we lost, unfortunately, some patients. It was a little bit of a challenge of training and some really interesting pathologies we saw. That was a patient, she was around 50. She came with her 25 kg bag of white sugar because she every time went into hypoglycemia, and she anticipated that. And her family brought her 25 kilo bag of sugar. It was almost empty. We assumed that she had an insulinoma, for example. Unfortunately, she died in the first night or second night in an hypoglycemia, where it was, let's say, our fault or my team's fault, my fault at least. But that are interesting things, pathologies we saw, like this one, for example, interpersonal violence. This man did quite well. It was just a soft tissue injury, but something you are not expecting as a doctor from northern or western Germany. And we have had to deal with bad infrastructure. We managed to renovate the acute care unit a bit. But these things, that is an educational problem. Huh? Something with someone with a tracheostomy and put the nebulization mask on the face. It's maybe not the appropriate way. This is teaching issue. That were the challenges we had to solve. And the advantages were that we had a highly motivated team. They were really willing to change, and they were willing to learn. And that was the whole success story. That were young locals, in the Namibian trained locals, they really were keen to learn and to get knowledge. And they took over after I left Namibia. And some interesting things like the burn wounds. And also we had the time that is a consultant from my group, that is a friend of mine, Prof. Chris Hunter from Georgetown University recently. He came to us. He has worked in Namibia for 8 years, but he took his time to run around with these children, for example, just to keep them calm on us. That is something we can't do in Germany, for example. That is something completely new for me. And we also got to train our medical officers in simple interventions, for example, bronchoscopy. It was completely unusual. This is Dr. Mukanana, very, very, very good medical officer. He's doing now the bronchoscopies on his own for internal medicine. He was trained for the ICU part by me, for the pulmonology part by a pulmonologist from Inselspital Bern. So he can do it now on its own, and he can facilitate the knowledge. I think that is all about. And what was also unusual when I came there was to mobilize ventilated patients in the chair. Completely unusual. And with a little bit of training, now it's usual that the nurses are mobilizing the patients. Just training and get them to understand why. Yeah, we did some interventions on ICU, laparotomy and severe bleeding. And so that was also unusual, but with the implementation of some protocols together with the surgeons, it was possible to do in rare cases. But to come to an end, and I apologize that I delayed the whole session, it's all about people. And it's all about people who took over. This Dr. Sikubi took over the responsibility as for the emergency department as well as for the acute care unit. And I visited him 2 weeks ago there, and it's running really smoothly. Of course, they have their challenges still. And a part of my nursing team and medical officers at the farewell party there, they are still keen to learn again and to continuously learn and to change. And that, I think, still has reduced mortality. They have taken over, and I think that is a kind of sustainability we wanted to have. Yeah, thank you very much for your attention. I'm looking forward to your question. I wanted to advertise 2 symposia we are organizing in Kiel online, something on cardiac arrest research and something on global health and emergency medicine, where we have, I think, compiled quite an interesting list of speakers in both topics. So if you're wanted to join, browse our website and register on Zoom. Thank you very much for your attention.
Wow, thank you very much. I felt like I was in Namibia for a while. Right, so now back to Singapore. And now we're going to have a different kind of talk on from the hospital. Now we're going to be looking at the region. So we'll have Dr. Paul talking about outbreak preparedness and regional health security in Singapore, in Asia. Dr. Paul, please.
Right, hear me okay? Great. So thanks very much. Hard act to follow after that incredible tour through Namibia. I just wanted to talk a little bit about something quite different and contrasting, and it really relates to trying to share some of our experience at the SingHealth Duke-NUS Global Health Institute with our colleagues here from Germany in terms of some of the work that we're doing and some of the contributions that we're trying to make to the region. So the Global Health Institute was set up in 2018, really as a coordination mechanism to try and support activities across the academic medical center that are already sort of engaged in the global health space. And the objectives of the work are to improve health outcomes, increase health security, and strengthen health systems. When I first arrived, I'd only been in Singapore for a year or so, coming from 5 years in Indonesia supporting health programming there. And when Prof. Tan recruited me, he was sort of pitching this as a startup, and I really got the impression very quickly that this is much more of a pull together, because all of the academic clinical programs and signature research programs are already heavily involved in the global health space. About 134 projects at last count taking place in 15 countries, supported across the range of programs in the AMC, which is a huge capacity. And within the Global Health Institute, we're organized in 5 themes around policy, research, innovation, clinical, and education. And one of the things that we're really trying to encourage is cross-disciplinary research that spans across the different themes. So a lot of the kind of complex public health challenges that we're facing today, whether it's COVID or climate change, requires different disciplines to work together to address complex challenges. And that's the sort of research that we're trying to foster here. So what I'm going to focus on for the rest of this talk is a very kind of concrete case study of the way in which we're engaging kind of outbreak preparedness as part of this new center called COP. Now, as folks may or may not know, Asia actually is got the highest risk of outbreaks anywhere in the planet. And the reason for that are due to population density, high levels of mobility, the fact that it's hot, and it's got a great diversity of animal species, and it creates opportunities for interactions between humans and animals in very kind of close ways that allows for pathogens to jump from one to another. Over the course of the last several decades, there's been an outbreak with a new pathogen almost every 2 years. And in the context of this, the question really isn't, whether there's going to be another outbreak, it's when. It may actually be now with monkeypox. What this graph demonstrates is one of the most catastrophic failures of global systems that I think the world has seen. While Singapore is vaccinating, 3rd and 4th doses, many countries in the region are somewhere between these 2 red lines, barely receiving their first dose. Coverage in Africa and Namibia is probably something like 15% receiving first dose. In Asia, it's probably about 30 or 40% as a whole. But this is a pandemic that we saw coming. This is a pandemic where we had the COVAX facility and the ACT accelerator and Gavi and UNICEF, and I take full responsibility for some of this, having been on the UNICEF side of this, just trying to get vaccine into country. But despite all of those systems in place, we really failed to achieve a substantial degree of vaccination coverage in countries that were hardest hit by the pandemic, where health systems were most fragile and communities most vulnerable. And this speaks to, this is a graph of access to vaccination, but you can equally say this is access to testing, this is healthcare spending, this is all the range of issues that Jan just sort of illustrated in his profile from Namibia, which is not necessarily that different if you take a plane 30 minutes or an hour away from Singapore in any direction. Hospitals in Ambon don't look all that different from that in Indonesia. So when one looks at our experience of the COVID pandemic, one of the silver linings is genetic surveillance. And this is when I get to bring out my prop. Yeah. So there are new technologies available to countries now that prior to COVID were only really available to research labs who are looking at rare genetic diseases. This is not promoting any particular brand. We manufacture unspecified, but this is a cartridge that you can use for genetic surveillance. Right. This is the device which you plug in the USB cable into your computer. On this cartridge, you can process almost 100 specimens and use it 6 times. And it can produce an answer on those 100 specimens in what, Ruki, like 6 hours or something like that, right? Getting nucleic acid sequences out of this. So this allows you to detect pathogens early, potentially, if it's done well. And it tells you, what the pathogen is, whether it's known or unknown, where it's from, potentially how it's related to other pathogens on its family tree, and whether it's of high outbreak risk. Right? And this is something we could never do during COVID. The second thing that's really important about the pandemic is the accelerated pace of science. So we can turn this genetic data into new diagnostics within days, no joke, days, right? That can be delivered at scale through PCR-based technologies and rapid tests, laminar flow. We can also reverse engineer vaccines, particularly using mRNA technology. Instead of a new vaccine taking 6 years, it can be done in 6 months. And that is extraordinary. And it's not just important for outbreak-related pathogens. This is a fundamental rethink in how we're approaching communicable disease control. The next thing that's important for regional health security is to strengthen health systems and laboratory capacity to be able to do this work, right? The technology on its own is not enough. We need systems that support it. And then finally, it's around an enabling environment. And this is issues around regulatory systems, supply chain, distribution, procurement, legal framework that allow countries to work together, clinician networks working across country that allows us to test products very, very quickly. So if we're really going to work towards an approach where regional health security is something that we all value and it's important, we need to be addressing all of these different prongs. So in this context, Duke-NUS is really trying to bring together a range of different actors from across Singapore to contribute to 4 different areas, and where we've already been doing work as an institution and as a country for the past decade and a half. The first is strengthening our capacity for surveillance and genomic sequencing. And that includes for human pathogens. It includes at the human-animal interface in wet markets or in areas where there's been habitat encroachment, and really trying to target those areas for genomic surveillance and improve capacity of countries in regions that are at highest risk to be able to do this in country on their own, right? In the past, most countries would sort of ship their specimens out to other countries to be processed. What we're trying to encourage is the development of in-house capacity so countries can do things independently. The second is to link that to access to new diagnostics, therapeutics, and vaccines. And there's a whole range of initiatives that are already taking place within the Singapore context where Singapore is really providing a hub of excellence to support things like advanced clinical trials network of 30 hospitals across 7 countries where people are pre-positioned to do trials very, very quickly. We also have something called translational medicine, which I'll talk about sooner, which is a way to do assessments very, very quickly using a deeper understanding of the immune system. Finally, there's a component of strengthening health system readiness and some work that we're doing on the enabling environment by looking at issues such as trade-related intellectual property rights, parallel licensing agreements, issues such as regional regulatory harmonization, and how to really get products into market very quickly in an emergency context. And all of these things are going to be important for countries, because if you're asking Laos or Cambodia to use something like this thing costs $900 a pop, right? And if you're competing with the kinds of realities that Jan presented in his presentation, where you're dealing with issues of safe motherhood, emergency medicine care, routine immunization, $900 a pop is a lot. right? So a country is going to ask, what are they going to get out of it? So if you're asking Laos or Cambodia to upload their genetic data into the cloud, into these new publicly available databases, they've got to get something out of it. And that something includes rapid access to products and systems that can really facilitate adoption and scale very, very quickly. So that in a nutshell is what our Center for Outbreak Preparedness is all about. In Africa, and by the way, yeah, so this is, in Africa, there's something quite similar called the Africa Pathogen Genomics Initiative. It's supported primarily by the Gates Foundation with a range of other partners. It's run by the African CDC, which is part of the African Union. But in Asia, we don't have a CDC. And ASEAN, frankly, is not as strong as it needs to be. And there's a lot of politicization of these issues between countries. So the Gates Foundation has asked us as Duke-NUS, because of the leadership of people like Gavin Smith and Lin Wang and John Lim and others within the campus, who are really proven themselves to be global and regional leaders in this space, to really approach this not on a government basis, but on a way of strengthening scientific capacity of researchers and scientists and program managers across the region. The countries that we're working to target are in South and Southeast Asia. The ones in yellow are countries that are receiving funding from the Bill and Melinda Gates Foundation, who are investing hundreds of millions of dollars in genomic sequencing and surveillance. For folks that haven't had a chance to read Bill Gates' new book on how to prevent the pandemic, it's all how to prevent the next pandemic. It's all about trying to use this technology and really amp up our ability to do early detection and developing new tools to respond to pandemics. The countries in orange are areas where we already have historical partnerships within Duke-NUS. We're approaching our work here in 2022 by conducting a landscape assessment to get a sense of what the status of these things is in countries. For a lot of countries, again, there was very little before COVID. And in the context of the pandemic, manufacturers have been donating equipment and reagents to countries in the hopes of kind of cornering the market sometimes, which has created some very kind of unusual dynamics. And that's what we're trying to understand before we kind of launch more formally next year. In terms of the kind of core work that we're doing, it's really around, as a university, these are the things that we're good at: policy support, capacity development, and sort of monitoring and operational research. So those are the key prongs of our work. From a policy support standpoint, the WHO just recently in the last month has released their global genomic surveillance strategy. And we have to now take that and translate that into national strategic plans, guidelines, indicators, and only then does this stuff get into domestic budgets. So you've got to go through that process. And this is where trying to understand how systems can be configured in an affordable, cost-effective, and reliable way at the country level is something that we're heavily engaged in. I won't go through this or that. The next thing that we're working on is this whole capacity development component. So in Singapore, what's really amazing, again, for me coming from working in low and middle income contexts for 25 years is you have so much capacity here, right? In Southeast Asia, there's only 3 manufacturers that make these sort of things. They're all, within a 5-minute car ride of here. Doors that we can knock on very easily. The laboratories that do cutting edge development of new diagnostics and vaccines are across the road, right? So this incredible concentration of capacity is really unique. So the idea is to really establish Singapore as a reference center that allows us to bring folks here for hands-on laboratory experience. Once you have this data that comes out of this, which is a nucleic acid data, not only is that important, but you also have to link it up to a supercomputer to tell you whether or not this is something that's serious. And a lot of countries don't have that capacity as well. That's called bioinformatics. In Singapore, we have agencies such as A*STAR, who've got about 100 bioinformaticians on tap who can support this work. So again, this real kind of concentration of expertise that will help us set up this Asia PGI training academy. Some of the priority areas that we're working on are around laboratory support, bioinformatics, strengthening surveillance systems, and improving regulatory procurement and supply chain issues. The link to clinical work is the link to new tools and technologies is something that I've already mentioned. This is mind-blowing stuff, which I'm not going to get into in much detail, but you know how, maybe a little bit of detail because it's so cool. Do you know how, people are measuring antibodies, right, for COVID? If you have a neutralizing antibody, that's really good, right? But that doesn't tell you anything about the immune system. And the immune system is far, far, far more complex than that. Translational immunology is a way of mapping the interaction between the entire immune system by labeling a number of different isotopes on different immune cells. And how those cells configure and move about is what really tells you how your immune system is responding to a disease. And you can use this to actually, for example, expose half the room to a vaccine, the other half aren't exposed. And by looking at the configuration changes in their immune system, you can tell in advance of doing a study whether that vaccine is going to be safe and effective, right? So it's just transformative stuff that, that when linked up with this mRNA technology can really help us accelerate the pace of science in new ways. The other interesting piece of research that we're doing is looking at issues around market shaping. As I mentioned, this stuff is very cheap. There's very few manufacturers, but as always, poor countries pay more for things than wealthy countries. So on the bottom graph is the price per sequence done in the US, which is about $18. And this is the price in Peru and Malaysia, which is about 10 times that. So, and a lot of the reason for that is because supply chains don't work, because people who manufacture these things don't have offices in poor countries, don't have distributors in place. And as a result, the distributors charge what they want, the volumes and quantities are low, and prices get very high for poor countries. So trying to understand the range of pathogens that are important to countries outside of COVID, whether it's dengue or typhoid or cholera or drug-resistant malaria, and how this kind of technology can be scaled up and how it's going to miniaturize and get even more accessible in the future is going to really, again, be a total game changer. So there's huge sort of market shaping opportunities working with these three manufacturers to drive prices down. And then finally, the plug to my previous employer, a lot of these companies now are registering their products with UNICEF. So what that means is that instead of a country having to go to a company to buy directly from them, UNICEF can procure on behalf of 100 countries at once, and that's called pooled procurement, and it massively drives down the prices. And then UNICEF sells to countries back at no profit, drops it off at the doorstep, and again, it's a much more cost-effective way of doing business. So in summary, it's kind of a last slide. What's cool for me, and I've worked in Africa for 15 years, in environments very similar to Jan's, where you're really starting from scratch, right? In Asia, things are kind of like one notch up. Like your average, say, primary healthcare facility in Indonesia would look similar to a secondary hospital, for example, in many Asian countries or many African countries. So laboratory systems are slightly better, human capacity is slightly better. Most countries, believe it or not, are already doing some of their own genetic sequencing. 90% of Africa, you can't even get a malaria smear when you need it, right? So for me, regional health security is achievable, but it's only achievable if countries start working together. So for me, what's exciting is creating this sort of collaboration platform that helps countries to address all of these boxes to achieve regional health security, because if COVID has taught us anything, is that we're only as safe as our weakest neighbor. So thanks very much for your time.
Wow, mind-blowing stuff. Thank you, Dr. Paul. Right, so next, from actually, hearing about an invention, we're going to be talking about the process of the development of a pre-hospital evaluation toolkit by Dr. Anjni. Dr. Anjni, please. And just a reminder that you guys can key in your questions in the Q&A box for those attending this session over Zoom.
Thank you so much for having me. I'm not sure how I'm supposed to follow that amazing talk, but this is going to be a little bit of switching gears. So I can do it from here. So I'm going to be discussing a project that we've been working in collaboration with Duke and Durham, as well as Duke-NUS and our partners from Southeast Asia. So what we've been working on is developing a pre-hospital quality assessment tool. And these are some of the partners that we've been working with. So next slide. No, it's okay. No. So just as a disclosure, this project was funded by the Laerdal Foundation. So to provide some background, low and middle income countries, as many of you probably know, share a disproportionate burden of disease, of mortality and morbidity due to emergency conditions, with an estimated 30 million deaths annually. And it's actually been estimated that a third of disability from emergency conditions and half of the mortality from emergency conditions could be improved by strengthening and further developing emergency care systems. So there are tools to assess pre-hospital emergency care, but many of these tools have been developed in high-income settings and validated in high-income settings. And we have found that there really haven't been any tools specifically geared towards low-resource settings to measure EMS or pre-hospital emergency care. Next slide, thanks. So many of you may be familiar with this diagram or this picture. So this is from the WHO. This is a framework for emergency care systems. And as you can see, emergency care is kind of divided into three main areas. So the care that's provided at the scene, usually from bystanders, the care that's provided via transport from emergency care personnel, and then care that's provided at the facility. So pre-hospital emergency care actually spans both scene and transport care. To date, much of the focus on emergency care has really been on the facility level, but emergency care provided at the scene and during transport is coming into more focus as we kind of understand that there's a significant amount of care that's provided at this time, and that there's a potential to save lives by improving care in these areas. So this is an overview of the tool that we're proposing with this project. So this is an example of a scorecard. We're planning on looking at three main areas: cardiovascular emergencies, trauma, and perinatal emergencies. And we're hoping to propose about 10 elements or metrics that will span across one or more of these pillars. And then providing indicators of quality of care through simple visualizations and colors. Great. Yep, that's okay. So we're doing this through three main aims of our project. So our first aim is to explore potential elements. So that's that list of 10 elements. And we're doing this through kind of multiple approaches. So this kind of, I guess, bleeds into aim 1 and 2. So we started with a qualitative survey of emergency medical services physicians, or EMS physicians, from 6 low and middle income countries in South and Southeast Asia. And during that process, we asked them to identify what elements they are interested in measuring in their own specific systems. Our aim 2 is really going to refine that list by adding on further information from a scoping review and a survey. And then our aim 3, once we've developed this tool through a consensus statement, will be to pilot that the tool in all 5 countries. Yeah, so this is just another overview of, thank you, of our project. So starting at the top, we're really getting information on our proposed elements through multiple sources. So we're doing a scoping review to identify what quality assessment metrics exist for pre-hospital emergency care systems, and then conducting our focus group discussions using the CFER method. So, and then quantitative survey results as well. So with those 3 processes, we'll come up with a master list. We actually met a few days ago with our stakeholders from South and Southeast Asia to start refining that list and start further developing this tool. And then in November, we're planning on having a consensus meeting and completing an eDelphi method to come up with a final list of quality indicators. And then eventually we will get to implementation of the toolkit using the REGAIN framework. So this particular talk is going to focus on the qualitative portion, which has already been completed. So we did a qualitative assessment of EMS medical directors in the following 6 South and Southeast Asian countries: Vietnam, Philippines, Thailand, Malaysia, Indonesia, and Pakistan. We developed a focus group discussion guide with input from our LMIC partners using the Consolidated Framework for Implementation Science, or CFER. So we conducted 4 focus groups and elicited barriers or perspectives on barriers and facilitators to implementing such a tool, and then also asked our participants to propose specific elements. So to jump to the results, so these are organized by CFER domain. So CFER domain 1 is intervention characteristics. And this is just an overview. I'm going to go into detail for each one of these broad findings. And this is not the complete list. This is just kind of the more pertinent findings. So intervention characteristics on the right, you'll see the de-identified quote from our participants. So what I find really interesting is that our participants really were interested in developing an Asia-specific tool. So they understood that many of the tools that exist are really not developed for their specific settings. And so that was a really interesting finding. They also indicated a desire to have a tool that was specific to other existing tools in Asia, such as the Pathos and PERC, and developing a dashboard that was similar. And then they also noted a need for generalizability for such a tool. So there is a saying in the US that is probably similar elsewhere, that if you've seen one EMS system, you've seen one EMS system. And I think this definitely applies here, especially when you talk about settings that are rural versus urban, and more high resource versus low resource. So they understood that going through multiple countries and even within country, there's going to be different settings, and that this tool needs to be able to speak to all of these settings. And then they also indicated that maybe starting out with 3 pillars would be too much for many of these settings. So they don't have the capacity to study or to look at all 3 disease processes or all 3 pillars at once. And so maybe they want to start on one small disease process before expanding. And that kind of speaks to this as well. So CFER domain 2, this is the outer setting. And we'll go into each one of these in detail. So public sharing or reporting of data was noted as a significant barrier to implementing such a tool as this. I'm sorry, back up. So they recognize the importance of public sharing or reporting of data, especially to stakeholders such as taxpayers and government entities. And then they also noted the need to benchmark performance across other systems. So whether it's within country or across countries, they wanted to be able to compare their performance to see how well they were doing. And then they also noted some data sharing challenges, particularly with respect to data that's owned by the hospital and maybe not easily accessible by EMS systems. And then CFER domain 3, the inner setting. So barriers to data transfer. So this is kind of similar. So in many of these settings, EMS data is collected by the EMS system and then transferred to the hospital. And then the hospital owns the EMS data. So they're not really even able to access their own data, which is kind of interesting. And then workforce shortages were also noted. In this example, they discussed a workforce shortage at the dispatch center. And then the need to further develop EMS systems before implementation of such a tool was also discussed. And then finally, CFER domain 4, intervention characteristics. So what was interesting was that our participants noted that they didn't think that pre-hospital personnel would have the buy-in for such a tool because it's going to involve additional work. Many of these volunteers or many of these personnel are volunteers or overworked in an already strained system, and they just don't have the time or interest in entering additional data or working on such a tool. And then belief that the intervention is going to improve overall care was also noted by our participants. So then we also asked our participants to identify potential elements to include in this tool. And so this is an overview of what they proposed. And so it's broken down by our pillars. So you'll see yellow here is our perinatal metrics. Blue here is cardiac, and then pink is trauma. And then we have a combination of trauma and cardiac, so those that spanned across both of those pillars, and then a combination of trauma and perinatal. And then in green, we have those elements that spanned across all 3. So in conclusion, our participants from this focus group discussions expressed the need for developing an Asia-specific tool and performance benchmarking. They also noted that such a tool needed to be flexible and adaptable to different settings and different systems with varying resources. And then among the identified barriers, data collection, transfer, and sharing were significant challenges to implementation. And then perceived lack of buy-in from EMS personnel was also noted to be a challenge and would need to be targeted in any implementation of such a tool. And then future work is going to involve refining our elements further through surveys and consensus meetings, followed by creating and piloting a functional assessment tool. All right, thank you very much for your time.
Thank you very much, Dr. Anjali. We look forward to the end product. So next, we're going to move on to another topic. So global health starts at home. You don't have to actually go across to a different country to actually practice global health. So we have an interesting talk by Ms. Leonie on the Cloverleaf Concept. So let's listen on to find out more about it.
Good afternoon, everyone. Dear professors, thank you very much for the opportunity to speak today to you about the Cloverleaf Concept, which is a concept for a strategic supra-regional transport of intensive care patients in worst-case COVID-19 scenario, and since March this year also for the Ukrainian war. First of all, I think I have to tell you just a little bit about how Germany works, because this is very important to understand the concept and the whole thing about Cloverleaf. Okay, so the state organization in Germany is that we have like the federal state, which consists of 16 Länder, which are 16 small states, and it's the principle of federalism. And all the states, the Länder, have their own state functions and their sovereignty. So each land has its own constitution and its constitutional autonomy, and also independent political institution. This also applies to the emergency services and to the hospitals and to everything that refers to that. So this is very important to understand how the Cloverleaf concept later on works, because all the 16 Länder or federal states have their own laws of rescue services. So we have 16 different ways of how they organize their rescue services. Okay. So what are we actually talking about? This is how the intensive care transport normally looks like in Germany. We have intensive care ambulances that are on the street. This is the normal situation. But then there was COVID-19 coming, and all of a sudden, in the very beginning of the pandemic, we had a big airplane from France coming to Germany that transported 6 infectious intensive care patients that arrived at one airport at a time, and we had to take care of them, and we had to transport them all of them together or at the very same time. So we didn't have any idea of what that meant, and we didn't know what to do when that happened to Germany, because those patients came from France, and all of a sudden people start to think, what are we going to do if we have a lot of intensive care patients, infectious intensive care patients in Germany, and what does that mean for our capacities in hospitals? So all of a sudden there was a mission in Germany because we had to coordinate care. We thought that we might have, or we needed a concept to coordinate care at a supra-regional level, and it was done by the Federal Ministry of Health and also the Federal Ministry of the Interior. They tried to develop the Cloverleaf concept. We called it, or I tell you later on why we call it like that. And it's a concept of a strategic supra-regional transport of intensive care patients in a worst-case COVID-19 scenario. I put you this picture on because it was a challenge about like that, because we had the 16 federal states, and never ever in the German history before the federal government and the 16 federal states had to work like this together. It was very unique and new. So we then had to transfer the concept and its structures, or it was a wish that was transferred to the takeover of patients from the context of the Ukrainian war that broke out in March this year. And all of a sudden we were confronted with a lot of patients coming from the Ukraine to Germany. So it was also a concept for capacity management, and normally intensive care patients in Germany are only transferred for medical reasons and not for logistic reasons. So this was new about this concept, that we wanted, especially for the pandemic, to transfer patients for logistic reasons, which is from one hospital to another hospital of the same level of care. Thank you. Because normally you put the patients to a higher level of care, but during the pandemic, we wanted to build capacities in one region and put the patients to the very same level of care, but somewhere else in Germany. So the goals of this concept basically is the coordination of structured strategic transfers of infectious intensive care patients, and newly since March this year, also Ukrainian patients, as well wounded as sick. In case of capacity limitations, in order to never get into a triage situation. We always wanted to be able to treat every patient everywhere in the country and not let a single patient die because there was capacity limitation. So we decided to build the so-called Cloverleaf concept. It's not that I put the wrong word, we didn't divide Germany into 5 so-called Cloverleafs, but we put together a couple of Länder or federal states to 5 Cloverleafs in total, so that the administration of organization of the strategic transfers is easier. So each Cloverleaf is consisting of 1 to 5 federal states, and each Cloverleaf is coordinated by a so-called single point of contact, SPOC, and within one Cloverleaf, the states support each other within the Cloverleaf. So the objective is to relieve a region where there's no capacity anymore for intensive care patients in the beginning, and put the patients somewhere else in Germany so that every patient can be treated. We have 3 different escalation levels. The green level, phase 1, is the normal everyday life. This is nothing specific. In the yellow phase, we talk about increasing demands. So this means that transfers happen within one Cloverleaf, meaning from one federal state to another within one Cloverleaf. The organization happens within the Cloverleaf. The interesting thing is the red phase. Then we have an overload situation, meaning that we have to organize the transfer from one Cloverleaf to another Cloverleaf, meaning maybe not 100 kilometers, but maybe 1,000 kilometers, which is very difficult for an intensive care patient, because those of you who deal with intensive care patients know that they are always at high risk. So then the transport organization happens on a national level and across the borders of the Cloverleafs. Which patient is to be transferred always is decided by a physician, every single one. We discussed about every single patient because they are intensive care patients, and we are still not in disaster medicine, but intensive care medicine in the beginning when we developed the concept. So there was always at least 2 or 3 physicians deciding about what patient is stable enough to be transferred over the whole country. We have operational level actors, which are the 5 SPOC, the single points of contact. They are in regular contact with their federal states, and they coordinate with and under each other. The SPOC can receive medical and strategic organizational support or advice as needed. There we have the COVRIN expert group. I will tell you what the COVRIN group is in a few seconds. And I have to read that now because the German name already is difficult and the English even more. We have a Joint Information and Situation Center of the Federal Office of Civil Protection and Disaster Assistance. And this office assists with the organization of transport at federal level, and the COVRIN expert group supports by providing data on free intensive care capacities. They have registers and forecasts and tools to see how the situation is somewhere else in Germany, because we don't want to put patients in a region that is has a capacity limitation tomorrow. We want to put them in places where there are still free places next week and next month. So that's why we have the different supports available. The Cloverleaf Expert Group is a division of intensive care, infectious diseases and emergency medicine at the Robert Koch Institute in Germany. The Robert Koch Institute, I think Jan mentioned it before, is a German federal government agency and research institute responsible for disease control and prevention. And Jan, JT and myself are members of the Cloverleaf Expert Group. That's why we are able to talk about this topic as well. The Cloverleaf Expert Group supports and advises the Robert Koch Institute on overarching technical issues in management of COVID-19 cases in the whole of Germany. It consists of leading experts from all over Germany. I think for the pandemic, we were about 15 people, 15 experts. And the aim is to provide highly specialized expert knowledge from fields of intensive care medicine, infectious diseases, and emergency medicine. And since March this year, the Cloverleaf Expert Group calls itself Cloverleaf Plus, because we have additional experts in pediatrics and trauma surgery, because we identified those as very helpful and to be needed for the patients coming from Ukraine. We don't only have the operational actors, but also a strategic steering committee, which is set up to assess the overall situation throughout Germany. And in addition to the 5 single points of contact, it includes 2 working groups, the Robert Koch Institute, the expert group Cloverleaf, and several federal ministries like the Interior, Civil Protection and Disaster Assistance, the Ministry of Defense, and the Federal Ministry of Transport and Digital Infrastructure. This is how it looks like. So this group meets every 1 to 2 weeks, depending on the actual situation. And you see here on the left, the 5 single points of contact, the 2 working groups, the Robert Koch Institute, the expert group Cloverleaf, and all the federal ministries. So this is really something that happens the very, very first time in Germany, that all these actors coming together and on federal level and on state level and working together hand in hand. So we still learn by doing how this works and what is challenging about that. What are we actually talking about? I showed you the picture in the beginning of the intensive care transport, how it's normally done. Now we have all of a sudden more patients at a time, it's not individual care anymore all the time. We have several transfers at the same time and over longer distances. So the objective still is to relieve situations with capacity limitations and still to organize the best transport for each patient and still put the patient to the right hospital as well. So there's a lot of communication to be done and a lot of coordination also. Therefore, we tried to figure out what means of transport do we have on the level of the Länder, of the federal states. We didn't manage to get all of the transport capacities because not all of them were told to us, because this is also something specific to the states. Some know what they have and some say, I have different regions and every region is individual and I don't know what my state is doing. So we tried and figure out what means of transport we have. But what we do know is that are the means of transport at federal level. We there have some helicopters, some ambulance aircraft, and 1 medical evacuation aircraft. Unfortunately, this one is going out of order by the end of the month, next month, sorry. So this is the most important means of transport in the case of the Ukrainian patients, because at the moment they come with this aircraft. So for COVID-19, we developed some tools to better coordinate the whole concept. For example, we developed recommendations for criteria for the strategic transfer of COVID-19 intensive care patients because we said we don't want to harm the patients. We want to keep them stable. So we divide, or we try to figure out what are the criteria that the patients stay as stable as possible. And we also said if they have to be transported by helicopter, we have to put limitations in context of weight and height of the patient and ventilation parameters, etc. For the Ukrainian patients, we don't have such criteria yet because all sorts of patients are coming from the Ukraine. They can have injuries, they can be sick, they can be small children, they can be others, like everything is possible. Whoever manages to get out of Ukraine can come to Germany. What are we actually doing? At the moment, patients from Ukraine are reported at European level. It's called CETSIS. We do an initial assessment. This is the Covrin expert group of whether limited resources are needed. Limited resources in this context are intensive care units, pediatrics, beds for severely burned patients, and internal patients, for example, oncological patients, because those patients in Germany had to wait for their surgeries for 2 years during COVID. So now it's very difficult to put Ukrainian patients in these beds and let the German patients wait another time. Then the query of capacities for limited resources happens in the Cloverleafs. Then the submission of an offer to take over the patients at European level is done by the federal office. If this offer is accepted, we do a medical assessment by Covrin with regard to requested disciplines, means of transport, size of hospital, and if necessary, special features like if we have siblings, children, that should be accommodated together. And then the organization of transport happens. As you can imagine, everything that we do, and because it's done over the whole of Germany and with an aircraft by the military, there's a lot of press going on, but we also did some publications ourselves, for example, with the criteria for the COVID-19 transfers. So there's a lot of press work and publications going on as well. What did we achieve so far? During the COVID-19 pandemic, we transferred 115 intensive care patients, 49 from Bavaria, which is the Cloverleaf area of South, 66 from the Cloverleaf area East, 33 from Saxony, 30 from Thüringen, and 3 from Brandenburg, and 9 federal states took over these patients. Now in the Ukraine war, this is the from yesterday, the statistics, there have been 515 requests for assistance to take over. We have examined 331 and 162 Ukraine patients have been taken over by Germany so far. This is by official channels because there is a high number of unreported cases or patients that are coming or crossing the border just like that. And we assume that this number is approximately 50 times higher. And the number is constantly increasing because, of course, the war is still ongoing. And we also know or assume that as soon as the sky is clear, as many patients as possible will be transferred to Germany by every means of transport that is available. What does it look like if we take over patients? This is from last week because the aircraft came to Hamburg, which is close to Kiel, where we are from. So we had a chance to go there and see the patients that were coming from Ukraine to see how do they really look like, and if that what we see on paper of the patients fits to the condition of the patients when they come out. Of course, we couldn't take photographs of the patients. I think that's clear. But it's very impressive if you have more than 40 ambulances and helicopters and the aircraft and everything. So yeah, that's what it looks like. My summary: the Cloverleaf concept for strategic transfers of patients has worked and will probably be applied for further scenarios. Also, I don't want to talk about the monkeypox, but you never know what else will happen. The cooperation between the various structures of federal and state level is unique for Germany in this form. And I think this is also a statement for future scenarios in I don't know what form. The scientific analysis is currently being carried out for the COVID-19 patients, but depends on various conditions and still needs to be optimized. For example, or in particular, the extent of transport trauma in COVID-19 ventilated intensive care patients still needs to be investigated. We still don't know if we did something good to the patients or not. And the expansion of the structure in the context of the Ukraine war poses new challenges for the partners involved, but so far worked very well as well. Thank you very much for your attention, and I'm looking forward to your questions.
Wow, thank you very much. I just feel like those pictures are quite impressive. I feel like I'm just back from Germany now. Right, so now we're going to have the Q&A session. So maybe we have the speakers in front, the four of you guys. Any questions from the audience?
I have a question to Jan.
Wait.
You talked about the referral of patients to your hospital with buses, like a lot of patients. Did you know that in advance, or did the other hospitals call you and told you what kind of patients you can expect?
It depends. We know that there are referral days and that usually patients in not severe conditions. That is for the casualty. So especially for big room, always a challenge because there are 50, 60, 100 at a time. And it's not only one region per day who is referring, but more than one region. And we were notified when the regional hospitals or district hospitals wanted to transfer severely ill patients, most of the times. It happened that there was just a patient arriving with severe head injury, for example, and you received a call as a consultant on call when the patient was already at resusc. So it was always a surprise.
Right. I have a question for Leonie. So just wondering, like, when we talk about the Ukrainian refugees, is there a limit to the number of patients you can take in a day? And what happens when you have more patients than you guys can bring back to Germany?
At the moment, the limitation of patients that we can take over.
I think it's the other mic. Yeah.
At the moment, the limitation of patients that we can take over is the mean of transport in the Ukraine, because there are only a few ambulance car or similar cars that can bring the patients from Ukraine to Poland, and from there they fly over to other countries. But for traumatic surgery patients, at the moment we don't have limitations. For all the other groups, as I told before, intensive care, internal patients, pediatrics, and severely burned patients, that is to be discussed before for each and every single patient. But you can add if you want.
Yeah, I think there is no official limitation, and it's the political world that Germany is taking over as many patients as possible. But it is a more or less competitive procedure with the other European countries. So the Ukraine or Poland, for example, it's usually patients within Poland, that there are refugees in Poland, that Poland is putting a request in the European CSIS system, and then you are beating on it. Say, okay, who first come, first serve. And it was sometimes the case that we have triaged, let's say, the papers of 20 patients, and Germany said, okay, we wanted to take those patients. It was already too late because they already, the thing already went to Sweden or to Portugal or whatever. So it's more or less a competitive system. And what runs completely independent of it, of the Cloverleaf system, is what small NGOs are doing. So as Leonie said, it's more or less 50 times higher, and what the International Committee of Red Cross is doing, because it's war. So it's the thing of the International Committee of Red Cross, and due to the Geneva Convention, they are working completely independently.
Hi. Thanks very much to all the speakers for all your very interesting perspectives. One thing that I can't help but notice running through all the topics is that of social equity and funding. For instance, in Germany, if you've got an ICU patient that's out of beds, we can harness air transport from military and transfer them across the whole country. But in Namibia, where the patient has a stroke and they have to travel 1,200 kilometers and only 1 or 2 survive, then it brings a message home very starkly. And if another country can vaccinate COVID patients 4 times, and they have the technology to do genomic sequencing very well, to me, $900 is not a lot. But yet in other countries, you have to struggle to build up an EMS assessment tool. Well, what it does is kind of demoralizing, because then if we are to decide to go into global health initiatives, and 1, how are we going to make it sustainable? And 2, if we are going into a country that's less developed, do we have to make hard decisions like, is this country's socio-economic background strong enough to be sustainable? Otherwise, I will not go in. I realize this is a kind of a hard question. That's why I'm addressing it to the whole panel rather than to any particular person. Thank you.
No, Prof, I think you've hit it right on the head. I think that's certainly what I felt well, just around the issues of health inequalities, which for me is really what inspired me to go into global health in the first place. And on the contrary, I don't get demoralized by the inequalities. I feel a certain sense of opportunity and responsibility to try to work as best that we can, because smaller changes can have a bigger effect when you're starting at that sort of low baseline. 20 years ago, about 40% of the world's population lived on less than $1 a day. And today that number has come down by 80%. And instead of having about 70 or 80 countries considered low income, there's only about 25 now. So the world has made extraordinary progress. And this was all what's sort of around the Millennium Development Goals. These are things that, that every child should have before they're 5, that every household should be out of poverty, that people should have access to basic water and sanitation services. These were thought to be abstract and unimaginable back then. But having kind of been in that struggle and fought that fight, in a very, close to the ground way, to me, it's always been amazing what can be accomplished when, groups of like-minded people really try to roll up their sleeves and get stuff done. So for me, in terms of my career in global health, it's been amazing how much that we've accomplished. In Indonesia, over the course of the time I was there, now 70% of the population lives in areas that are malaria-free, which is a heck of a lot to save in a country of 270 million people on the equator, where there's 5,000 inhabited islands. It's almost an impossibility, but it's by the hard work of district managers and community malaria officers, and using the best of technology and capitalizing on new innovations, that we can do things now that we never thought possible. And I think we're also sitting in the middle of what is nothing short of a medical renaissance of med tech and data tech and just new ways of thinking. Singapore is going to have to face this because it's going to a model of capitation, but in many areas, things like telemedicine, remote consultations, AI are essential because there are no specialist practitioners. So there's so much more that we can do, and I think we can really accelerate the pace of change more quickly now than ever before in history.
And I think the question is, does it demotivate you or does it motivate you? And I think from the personal perspective, so you have your perspective from the United Nations level and from the UNICEF level, or you have the perspective from one more or less big hospital, it's up to your personality. I think for me, it still motivates me to go on there and to give, for example, my lectures to our students there remotely via Zoom, because one can see that they are improving and that these young colleagues will improve the system. That is nothing we can do as foreigners there, but that is something they can do for their own healthcare system.
Thanks. I don't know how much more I can add to that, but I would agree. I mean, I think it does take a special sort of person to want to go into this field. And I will say that there is some component of finance that is tied to doing any sort of intervention, but I think there's also an opportunity to be creative and to engage local stakeholders and to make sure that we're building capacity and not just kind of jumping in, parachuting in, trying to fix things and then parachuting out. So, but I think hard work kind of is the basis of wanting to do global health. It's not going to be easy, but it can be very rewarding and fun.
Any more questions? Thank you for your answers. Okay, I guess I just have one last one since we're talking about emergency care. So, okay, time. So, for everyone, so what role does emergency care play in global health?
I think I may have already answered that question in my presentation. So, I mean, I think that emergency care is kind of the first stop in the healthcare system, at least from my perspective. And so, especially when it comes to acute care conditions, there's just a lot of opportunity to reduce the burden of disease by addressing gaps in emergency care systems in low and middle income countries. So I think as the emergency physician, there's a lot of opportunity to leverage your expertise in addressing some of these gaps in other settings.
I have the more a perspective of disaster medicine or disaster management, and we talked earlier with certain of our colleagues here from Singapore about global health and different topics that can play a role there. And I think emergency care is the link between global health and disaster medicine, I would put it like that. And you have to look at every perspective, and emergency care plays a major role, but not the only and one and only role. So, yeah.
I think as I try to convey in my talk, with simple interventions in emergency care, you can really improve outcome. And what we have seen during my 2 years in Namibia, for example, that we have reduced the mortality on the unit from 50 to 60% when I started there to 20%. That is, of course, by far not as good as it is in developed healthcare system where the mortality on ICU is maybe 1, 2, 3, 4%. But it was all cheap interventions, and it was all about education and a little bit of equipment. But we had no money to invest in equipment, to be honest. So it was mostly about interventions and training interventions, and it had a big impact on the reputation of the hospital, and of course on the patient's outcome.
Probably should leave it to the emergency specialist, but you know, if you're doing maternal child health, everything is protocolized and clear what you have to do at what step of the equation. If you're doing chronic disease, it's also reasonably clear. But the major burden of illness between 6 and 60 is related to accidents, violence, trauma. You know, it's a real area that's ripe for global health innovations, because it's really unclear what to do, and it's so contextual, which I think is what was presented today. So it's an area where, you know, what's going to work in one context isn't going to work in another. It's an area that's ripe for low-cost innovation, particularly in low and middle-income contexts. It's ripe for a better use of information to inform decision-making and triage protocols, and where to place, you know, certain essential equipment and laboratory supplies and human capacity. But there's no roadmap. So it's blue ocean. and there's not a lot of work happening in that space. So it's really exciting to see the group from Germany here, and to see Marcus's incredible leadership in that space. So for me, it's been fantastic to work with the group, and look forward to continuing to do so. So thanks, guys.
Great, thank you very much. So last, we'll have Prof. Marcus Ong to give the closing address.
Okay, so maybe just some closing remarks, which my thoughts, as I was listening to this event. First point, I think what comes across very strongly in some of the talks and all that, I especially appreciated what Paul was saying, is the opportunities that are before us, as being in Singapore, being at the hub of basically some of the leading scientific and health advances or developments in the region, being in the center where we have good links, good networks to the neighboring countries, and we are in a position where we can partner with many people, and I think this is a privilege that we have as Singapore, but it's also a responsibility, that we have some of the resources that others would dream about, right? We have some of the talent that others would dream about. We have some of the capabilities that others can only dream about. But here we can make it a reality. And so I think that speaks to something that all of us we can think about, and how can we contribute, not just within our own communities, our own country, but in the bigger community that's out there. Second, is that the role, and I'm speaking to my emergency medicine colleagues here, that I think there are unique opportunities in the field of emergency medicine. We are dealing basically in time-sensitive conditions that have a big opportunity for intervention and improvement, and a lot of it has to do with systems level investment, and that's why we say it takes a system to save a life, right? It is not just about the quality of clinical care that an individual can provide, but it's being able to link that together in a system of care, right? That can actually bring the patients through from, acute injury, for example, to community-based first aid, transport, emergency department, operating theater, recovery, rehab, and back to the community again. And it takes basically people who are trained to think in a systems level, people who are able to think in terms of multidisciplinary collaboration. And guess what? That's what emergency physicians and nurses are trained to do. So I think there is a big opportunity for us to contribute, and it's up to us to actually see the areas that we can actually make a contribution. And then finally, the last thought I have is that the world is actually getting smaller. Today we have friends and colleagues from Germany, from United States, from Canada, right? Many other countries that are represented here from Southeast Asia and Asia. And more than ever before, it is about coming together to solve problems, using a diversity of skills, of background, of abilities, of talent, right? And together we are able to solve problems better than trying to do it alone. So with that, let me express my appreciation again for our speakers today, for the team, organizing team, Gayatri, Dr. Gayatri, and our colleagues from SDGHI and EMACP, who have put a lot of work behind the scenes. Our guest speakers from Germany, all for joining us. And we hope that you have had a good time and a good time of learning. Thank you very much.